Good afternoon, everybody. So welcome. I'm in sunny Lancashire. Actually, it's not sunny Lancashire. I'm looking out from the top of the house and it's absolutely pissing down. So welcome to the webinar, the second of the day from British Academy of Restorative Dentistry and Professor Tipton. My name is Matthew Holyoke. I'm going to be talking to you about Nearly Isolated, the dark arts of Rubberdam. Lockdown has not been particularly kind to me, as you can see. Thank a deal for the images on the left-hand side. My glasses have remained pretty stable, but I certainly can't wait for the hairdressers to open. So Nearly Isolated, which is not good enough. The dark arts of Rubberdam. So that expression, nearly right, what does it mean to you? Well, nearly right, yeah, very much a compromise. And when something is nearly right, it's very much wrong. So nearly right won't do, and nearly isolated will not do. Because nearly isolated means leakage and failure. So adhesion in Latin is to stick. And as we know, when there's saliva, moisture, blood, we do not get adhesion. So if you're a great big fan of cotton wool rolls, now would be the time to switch off because we're going to be talking about Rubberdam. Cotton wool rolls do have their place, but judicious and careful use of cotton wool rolls to supplement your dentistry. Because cotton wool rolls can result in this. Now, this is obviously somebody who, they thought about Rubberdam. They had the kit, but sadly their technique was lacking. And I wouldn't have wanted to phone my defense union or correspond with lawyers after an incident like this. Or this. Was it a poorly fitting chrome? Possibly so. So Rubberdam, designed in the United States, allegedly in 1864 by Sanford Christie Barnum. And this is in Wikipedia, this is called Dental Dam. And Wikipedia is quite a useful resource, and it gives you the background of Rubberdam, the history, current practice, how we use Rubberdam, how we apply it, the advantages and the disadvantages, and also some of the differential uses of Rubberdam. And you'll see right down at the bottom left, actually it's used for safer sex. I'm not going to discuss that in great detail. If you're interested, get on Wikipedia. Interesting. So during COVID-19, I've been part of a WhatsApp group up with my friends from Scotland. And it's been very entertaining. We've kept each other sane. We've come up with ideas. We've been ducking and diving. And one of my pals up in Scotland who's got a great practice in Glasgow called Paul Trevisan. And Paul emailed me this morning. We'd been reminiscing about Rubberdam, and he was mentioning about what it was like in the Child Dental Health Clinic. And this was what Paul quoted, and he said, the kids' clinics were all open plan, and you had loads of kids all waiting for treatments outside. Students spending most of the clinic trying to put Rubberdam on, and believe me, it was terrible, and screaming children. So these children were referred in by general practitioners that couldn't manage the children. And you ended up doing NOUT in the clinic as Jimmy Reed pontificated on it all. Jimmy Reed was the head of child dental health, Rubberdam, prevention. And as Paul says, he can't tell you how many treatments were abandoned because we couldn't get the Rubberdam on. So Dr. Jimmy Reed was the senior lecturer, and Dr. Jimmy Reed put me off Rubberdam for life. So I qualified in 1988. And this is a picture of Jimmy Reed from one of the yearbooks from 1988, 1989. When is rubber dam not a rubber dam? When it's a wee Johnny. That was the quote in the yearbook. So I qualified, never wanting to use rubber dam ever again. But through a career, it suddenly gets more and more important as we get more advanced with our techniques. And I'll give you this quote from Ireland in 1962. Probably no other technique or instrument used in dentistry is so universally accepted and advocated by the authorities, but so universally ignored by practicing dentists. And that was certainly true for me. I qualified in 88 and decided, one, not to do orthodontics, hated it, boring, couldn't do it. And two, never to use rubber dam. But life does change. Why does it change? Because of COVID. So now we all know the benefits of rubber dam, even more benefits of rubber dam, because it can reduce your fallow period. So by using rubber dam, you can reduce the bioaerosol by up to 90 to 98%. And that was in a paper, Cochrane et al. In 1989. These are cited in a lot of the FGDP guidelines that were done by a colleague and a great friend of mine, the Dean of FGDP, Ian Mills, and his group. Great, great paper. And Mills has worked really, really hard over CV19. He's also on our WhatsApp group. So rubber dam reduces bioaerosol by 90 to 98%. Also, high volume aspiration. And you should ideally have a diameter the size of 8 millimeter on your aspirator tip. It's quite a large bore aspirator tip. Don't go down too small because it reduces the high volume aspiration. So by using high volume aspiration, that also reduces aerosol by about 90%. So this is going to keep CQC quiet. This is going to keep Sarah Hurley quiet. Use rubber dam, high volume aspiration. During CV19, Simon Pearce from McKillop Dental has been hugely helpful for dentists, certainly in Northwest. Simon's based in Southport, and his number is on the screen here. Take a snapshot of it, because they will, at McKillop, they will come and check your suction. They're actually servicing some of my units today. Inadvertently, they've set off the fire alarm, which has been a bit of a panic until about 20 minutes ago. But fantastic company, McKillop Dental, based in Southport. They'll give you lots of advice. They'll come and do your suction. And by checking your suction, make sure it's worked. Because with your aspiration, your high volume suction, high volume aspiration, your units should be delivering more than 250 liters per hour. Is yours working? You know, are you just getting a very slow gurgle and you're forever not getting the aspirating properly? Then get it serviced, get it checked. So Simon came to our practice about 2 to 3 weeks ago, checked each surgery, surgery 1, 333, surgery 2, 365, and surgery 3, 291. So all above the threshold that we should be having for high volume aspiration. Ticks the box. Sarah, yes, we've got it. We've done a risk assessment. CQC, yes, we've got it. We've done a risk assessment, coupled with all the other things we're going to be using to reduce that fallow time. So rubber dam is ideal. It's predictable, gives us control over humidity, safe, no clamps going down the throat, no dentures, no crowns. Many times I've dropped crowns down patients' mouths. Fortunately, they've all been recovered with a sieve and a fork. It's more comfortable generally for the patients. Occasionally you'll get a patient complain about it, and it's very, very efficient. And it also stops the patient talking to you, which is fantastic. But yes, there's a learning curve. Is it time consuming? Yeah, adds a few more minutes. Is it uncomfortable? It can be, but give local anesthetic. So it provides a dry working field, a large working field, retracts the tissues, minimal interference with your restorative procedures. You know, why would somebody not use rubber dam? So post-COVID-19, rubber dam is hugely important. As we said, aerosol reduction. Try and position it over the patient's nose during this transition period. Again, it reduces the risk to dentist and nurse. Try and do quadrant dentistry. Maximize your aerosol generated procedure. Do 2, 3, 4 fillings all at the same time. Rather than doing shorter visits, do longer visits. Clean the exposed teeth with 5% hypochlorite and high volume aspiration. Really, really important. Never mind about fogging machines. I use them, I've got them. Do they work? I don't really care. It's just a tick box for me. I've got air purifiers. Do they work? Don't know. They've got nice green light. But for me, rubber dam high volume aspiration is the key to reducing my fallow period and the open window. And remember, wash your hands. So for me, one of the gurus of rubber dam is Stefan Broat from Belgium. Absolutely the Harry Potter of rubber dam. And I've followed his YouTube tutorials for the last 5, 6, 7 years. And I've learned an awful lot. Believe he is going to come to the UK. They are going to do some online courses. Really, really would urge you, do a search on him on Google, put PDF on. You'll get some really fabulous references to help you with meticulous dentistry and isolation. So today's webinar, we're going to talk about what do you need and how do you use it. So if you're in a practice, you can go to your principals and say, look, we've got to reduce the fallow period. We've got to use rubber dam. This is what I need. I need you to buy it. It's not an expensive technique. And once you've got it, how do you use it? So the best dam, it's good because it's cheap. I use this Unident one from Dental Directory. I prefer the heavy. You get much better tissue retraction. So 6 inches, light blue, it's cheap, latex free, doesn't rip like all the stuff you had to use in dental school did, which was crap. So it's a good quality, latex free rubber dam. Well. Why heavy? Because it's less prone to ripping. It passes through the contacts far easier, and it gives you much better tissue retraction. Much better tissue retraction. When you start using thin or medium, you won't get that tissue retraction. There is more prone to ripping, and then it gets frustrating. Then you throw it away in the corner. Don't use it. You get the cotton wool rolls and you wing it. So I prefer the non-latex. It's safer for all patients and staff. Color, why light blue? I like light blue. You know, I like blue etch. I won't use green etch. I won't use purple etch. It's got to be light blue for me. Gives a better contrast for photography and a bright field for your photography. So light blue rubber dam for me. But there are alternatives. This is a really, really exceptional dam. It's a non-latex dam made by Roeco, and it's purple. Really, really good. Very, very flexible. Not as thick, so it's not so good for tissue retraction, but you can really expand it over large clamps and large teeth. So where do you put your spaces? Where do you put your holes? Harking back to university, this is what we had. Very old-fashioned, but it's a good old stamp. And you stamp all the sheets, and it'll just give you a rough position. And lots of dentists will find that gives you the guidance that you need to help accurately plan the hole punch. So very easy to get, very cheap. This is a really useful thing. It's called a pack dam. You can't get it from your Shine, your Rights, your Dental Directory. You can get it from the Facebook site. It's an Italian company. They're about between 25 euros and up to 40 euros for the metal one being the one on the screen here. And you position the frame on the top right of your dam, and that indicates your areas to place your hold. If you're doing the upper 6 or lower 6, you invert it. If you're doing a single tooth, you can place it there. If you're doing quadrant dentistry, you can do it there. And this is 4 to 4, 5 to 5, etc., etc. Very, very useful thing if you're struggling with where to put the holes in your rubber dam. I tend to just eyeball it because I've done it for many, many years. So PacDam, get on Facebook, order it, 30, 40 euros, not expensive, very, very useful bit of kit. If you don't want to spend 30, 40 euros, just get your rubber dam, make a nice big cross in the middle. And if you're doing single tooth, you just place the hole in that sort of towards the middle of your cross in the top right or the top left, but that's ideal for single tooth dentistry. Endodontics, maybe single occlusal if you're just doing that. You don't need to expose a whole quadrant. But when it gets to more complex restorative dentistry, say you're doing anterior 5 to 5, you want to be positioning the holes more like this. And if you're trying to expose, cover the nose, you want to be moving these holes down a little bit. In normal pre-COVID, I would be putting the holes here, but post-COVID, to cover the nose, I'll maybe move it down a little bit just to cover that nose. And if I'm doing quadrant dentistry, again, this helps me depending on the number of teeth you're going to put through. So that's how I'm going to put my holes in the rubber dam. When you're looking at the size of the holes, assess the tooth from the cervical, not from the incisal occlusal. Increase the spacing between the holes if you're going to use multiple clamps. We'll talk about clamps in a few minutes. And ideally, very seldom would you ever have to make the spacing less than 3 millimeters. That would really only be in a case where you had severe imbrication, one tooth in front of another. So very seldom less than 3 millimeters. So assess from the cervical, not from the incisal or the occlusal. What am I going to need in addition to the rubber dam? So you're going to need some waxed floss. You might need to use some wedgets. I usually just do the medium, which is the yellow. You'll see PTFE tape. Can't do isolate teeth without PTFE tape. You may need some cords if you've got any bleeding. And I would strongly advocate the use of a blockout gel. This one by Voco, very reasonably priced. Really good bit of kit, just like Cure Blue Gel, which we'll talk about in greater detail. Frames, what frames? I prefer this frame. This is the plastic frame. It's a 6-inch frame. This is the Hygienic 6 or a Visiplastic. And remember, the frame can be activated in a traditional U shape, where you've got the bow at the patient's chin. But you can also invert it and use the bow at the top of the patient, and that will help exert more pressure to pull the dam tighter if you're doing anterior teeth, upper anterior teeth. So you can use it both ways. So I prefer the plastic, but the other option is the metal one, which is the Young's frame. And arguably that will get you better attachment to your dam. It won't become loose so much. But I prefer the rigidity that the plastic gives me. We use a punch, typical Ainsworth punch. It's got different size holes from very small to very large. You seldom need the very, very large one. And you've got the forceps, various different patterns. Now, what clamps are you going to use? I use this system, which is made by Colting, and the Hygienic system. And these are the Fiesta color-coded ones. So as you can see, each clamp has got different color coding. These do wear out with repeated autoclaving, so get some nail varnish, get ready to repeat it. It lasts for a few more weeks and you just keep going. So it comes on this nice little stand. The color coding makes things very easy for your staff. Ordering is easy. Putting them back together is easy. They don't have to think, oh, that's a 13A, that's a 12A, and 8A. They just go by the color. And it also tells you the 12A should be used for this, 4 for that, number 2, the 9. So it gives you some nice little tips, which we'll go through. So stability and position. So I would always urge you to give local anesthetic, unless you've got a very, very big tooth with a big crown, maybe a non-vital tooth, you might get away with it. But if you just give a touch of local anesthetic into the tissues, labial, palatal, buccal, lingual, it just gives you that confidence to place that clamp without getting the patient to jump. Because if the patient jumps, they're then less inclined to allow you to do it a second time. So give a bit of local, explain the reason why. Then you put your anchor clamp on. Ideally, minimize your number of clamps. If you can get away with 1 clamp, do so. Occasionally, you'll see when we do hands-on of this, people are putting clamps all over the shop. And if you do that, they get in your way. You can't work with them. And ideally, your clamp should have 4-point contact. So each of the tines, the prongs, should contact stably with the tooth. And have a large selection of clamps, because each tooth is individual, and you need to have a selection so you can choose the most appropriate clamp for that tooth and that location. Is there a rotation? Is there crowding? So your anchor clamp is traditionally, or is always, the most distally positioned clamp. And that's the first one you put on. And that withstands the mesial distal pull of the dam. So it gives you stability. On occasions, you might need an additional clamp, but wherever possible, get away without an additional clamp. The clamps I most often use for either endodontics or restorative are the 2, which is for smaller premolars, the 2A, which is for premolars and molars, the 13A, which will do me for upper right and lower left, and the 12A for upper left and lower right. So very, very simple. The number 9 butterfly clamp, it's in the kit, hardly ever use it. I actually would, although it's designated for anterior use, there are occasions I might use that posteriorly if there's recession on a mesiobuccal root, things like that, but hardly ever used it. It's too big, too bulky. I don't like the shape of it. So the clamp is made of the bow and the bracket here, and you've got, these are winged clamps with your, obviously your location holes. These are the wings, and it just flip that over. So we look at these so-called tiger clamps, the 12A, which is yellow in the Fiesta color-coded system, and the 13A, which is the pinky purple. So the 12A does the upper left and lower right. The 13A does the upper right and lower left. Look at these serrations. So that these so-called tiger clamps gives you really, really good primary stability. These serrations really, really help. So that's going to give you even more contact, more than just 4-point contact. But your main contact is here, 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 and here. And you'll get additional depending on the shape of the tooth. One thing to look out for is this separation here. This shows you how active the clamp is going to be. As it gets wider and wider, it loses activity. And as it loses activity and tension, there's more likelihood that that clamp can ping off. Does it fly out the mouth or does it fly into the mouth? So the serrations increase the points of contact, increasing stability. Talking about the tension, look at this. These are 2 clamps, both the same patent number. They're both 12As. The one on the left here is brand new. The one on the right has been through the mill a bit. I've probably run over it on my stool. I've flung it against the wall. Look how wide the separation is there. That's now in the land of the dead clamps. It's gone to the scrap heap. It's no use. So check the clamps. The 8A is pretty good for partially erupted molars. This has got the black color coding. Look how aggressive these prongs are. But partially erupted molars, give some local and then stick it right in there. Get it in there and it will give you great stability. Really aggressive clamp. But if you look at the concavity here, it can sometimes cause you problems. We'll talk about the problems created by that concavity in a minute. Other useful clamps are the H2, number 2 clamp, which is color-coded brown, and the 2A. The 2 is smaller, and that's good for premolars. The 2A more for premolars and molars. On occasions, you may find that these clamps with the wings, or any clamp, these wings can sometimes get in the way. They might get in the way of your matrix band if you're doing a garrison sectional, might get in the way of wedge placement. So do bear in mind, with a heavy heart, get a tungsten carbide burr, and if it's in the way, get rid of it, cut it off. Doesn't mean you can't use the clamp again. Really useful clamp system is the Brinker clamps. Can't remember who make these, but they really, really useful. The B5 down the bottom, that's really good for anteriors. And that B4, really good for anteriors. Particularly if you're doing veneer cementation and you're wanting to use rubber dam, really retracts the tissue. These are not winged clamps. Very, very useful. Come in a kit, not expensive, 45, 50 pounds, something like that. So the Brinker clamps, good one to have on it for the tough cases. This is a really good clamp, the Hugh Freedy 212, anterior clamping. Great, again, for veneers. If we compare it to, it's a non-winged clamp, if we compare it to the number 9 out of the Coltine kit, this is way more tension, retracts the tissue better. An alternative to the Brinker B2. So the 212 or the Brinker B2 are the clamps I would use for anterior teeth rather than the number 9 butterfly. The 14A, very aggressive clamp. Look at the angles here. Again, really good for partially erupted teeth, but give local. Look at the tension on that clamp. Look how close they are. So once you get that in position, that isn't going to shift at all. 26N, another one good to have for molars. These are wing-free clamps, and a 27N, again for useful clamp. Have them if you want them, but you can do nearly every procedure with that hygienic kit. Soft clamps, I hate these, hate them. Palamine over in Burnley, Nadim Yunus, who does some courses with his Northwest Dental Academy. I think Nadim uses these, he likes them. They're very soft. Often you probably get away without using local anesthetic. But in my opinion, there's no tension in them, and I think they're crap. Just don't like them. But experiment with them. So the soft clamps by Care may work for you. Once you've selected your rubber dam sheet, you've put your holes in, you've selected your clamp, you've got it in position, you need to invert the dam. And what does inversion mean? It just allows you to get that rubber dam sheet sitting passively in the cervical area of the tooth. And once you've got it sitting passively, you then develop it and slide the rubber dam into the sulcus. And by doing that, it gives you excellent soft tissue retraction, which is the icing on the cake with your rubber dam. So to achieve good inversion, use a heavy, thick dam. It's much more efficient than using a thin or medium dam. Make the perforations small. If you use the very large hole punch on your Ainsworth, you've got a lot harder work. It's going to leak. So small perforations, dry the teeth, 3-in-1. That might give you some inversion, but very inefficient. Use the floss pull through. Show you that, really, really useful. You may also want to develop it using a flat plastic. Again, you've given local, so it's not going to injure the tissue, injure the patient, cause any issues with the pain, and use a flat plastic. And the real winner for inverting the dam is floss ligatures. And by using all these techniques, you can get up between 1 and 1.5 millimeters tissue retraction. Really, really fantastic when you're doing anterior composites, when you're doing diastema closures. By inverting the dam, it gives you fantastic tissue retraction. Gives you confidence then to work. This is what I mean by inverting the dam with the floss pull through. And you can just slide the floss through, and then if you do a little crossover and then slide it down, and this will give you partial success. But in my opinion, most of the time you'll need to do a little bit more, and that's where ligatures comes from. So we're going to use waxed floss, and by using ligatures, it really improves the seal. It really improves the tissue retractions, gets you that 1.5 millimeter of tissue retraction. And you can also use a ligature to anchor your main clamp as well. So this little video will talk you through the technique. So here we're making a V. Left hand, right hand pinch, left hand pinch, create a loop. Not letting go of my right hand, create a single loop. So this would be a single floss tie, but this would be prone to slipping. And now pinch with the left hand again, not releasing again with the right hand. Create the loop, keep the fingers within the loop, and you'll see now the double knot coming to slide around to join the single knot. And that is our double floss tie. Advantage of this then, you can activate the knot by just one hand, mesial and distal sweep, as it will tighten around the tooth of the floss tie. So floss tie is really, really useful. And you may, if you struggle doing them, get on YouTube with your pause button, advance it so you get to the position where you're confident with the technique. Once you do one, then do another, keep repeating it. If you really want to, make 100, have them in a box. But I personally like doing it in front of the patient because it gives a bit of theatre. It adds a little bit of detail. It shows the patient why you're spending that time with them and why this technique is better. And that it's a bit like Dynamo or Harry Potter. You do it right in front of their eye, bang, bang, bang. We were working this week, and my young nurse, Elise, and I was making a load of ties, doing the ligatures, and she suddenly handed me one. And she sussed out the technique herself. And I said, how did you do that? And she said, oh, it's only a couple of knots, isn't it? And she's right, it is only a couple of knots. So we now work very efficiently. Sometimes she'll make them, but I still like to do it in front of the patient. So floss ligatures are fantastic. It gives your dentistry a little bit more security. Photographs look a lot more European, makes you realize your dentistry look more efficient. So this is what I mean by the ligatures. So on the top image here, we've got the dam in place. We've maybe used a bit of a flat plastic, not quite got it there. So pretty good inversion, but there's more tissue retraction yet. These are our models. So we get the ligatures in, tighten, and then that pulls the tissue, gives you much better visibility, much better tissue retraction. So learn the art of floss ligatures, really, really useful. Doesn't take any time at all. If you get any bleeding, so you've placed your rubber dam, you've got a little bleed around, so you don't start your restorative dentistry. Don't think, oh, it'll go away. Get the bleeding under control, first of all. This pretty good material, Viscostat Clear. Try not to use the brown one because it does contaminate because of the ferric sulfate. Another good material is made by 3M called Astringent Paste. It's a light blue, thick paste. So if you've got a bit of a bleed, stick some of that down underneath the dam, then get your ligature on. So control the bleeding as soon as you can. The other great thing you're going to need is PTFE tape. And we use PTFE tape in a lot of restorative dentistry, sealing root canals, in between visits, etc. But PTFE tape, really useful for rubber dam isolation when it helps to protect and augment the dam. I'll show you using an number 8A clamp in a few minutes. Because sometimes the dam loses contact with the contour of the tooth if you've got a particular shaped tooth, effication into proximal areas. And you can use a PTFE scarf as a 360-degree loop around the tooth, particularly for onlay cementation. So you've got good isolation, you've got your rubber dam on, you've got your ligatures on, but just using a PTFE scarf around it will make your clear up a lot easier. It enhances your isolation and it minimizes any excess cement getting down underneath into areas, into proximal areas. Because once you've got that cement there, it can be really difficult to clean out. So the PTFE scarf, really, really useful. Talked about the 8A clamp before and how aggressive it is, and look at the convexity. So you've got, this is doing a single isolation, single tooth isolation, and you may just see here, so we've got, it's a wing clamp, we've got the dam over, but this is an area of weakness. So we could use a blockout gel, or we can use a bit of PTFE tape on the lingual and the buccal where there's any potential leakage, and even then do some block out on the top. Just again, it's extra reinforcement for your isolation technique. So how are we going to do it? So we're going to isolate a quadrant lower left. We're going to do from 3 to 7 in this case. Could do 1 to 8, but why bother? We're going to do 3 to 7. So we're going to put the clamp on and the dam together. You don't have to do it this way, but if you put the clamp on its own first, which some people do, and they find it easier to see. They've got easier access, easier vision, particularly if they don't wear loops. If you put the clamp on its own, you must ligature the clamp. Because if the clamp breaks and goes where you don't want it, down into the throat, you need to retrieve it. So we'll talk about how to ligature that clamp in a few minutes, but we're going to put them both together. This is my preferred technique and one that I would do probably 99% of the time. So I've given my local, my anchor clamp, in this case is a 13A. I place the dam and the clamp together. In terms of hole size, we're going to go a larger hole for the anchor clamp, and then I'm going to go small holes. Probably not the smallest, the second smallest. Put the dam and the clamp on together. Ensure I've got good 4-point contact. And then I'm going to flip, put the frame on first of all. I put the frame on as quickly as I can because that creates some tension in the rubber dam. Once I've got the frame on, I'm going to flip it off the wings. And the dam then will go underneath, and you'll see the hole, blue underneath the hole. Still got my 4-point contact, 1, 2, 3, and 4. And I'm then going to floss the contacts. And I'm going to use a double link of floss to go through the contacts. And I'm then going to use that as a secondary, once I've gone through the contacts, to do my floss ligatures. I'm going to put a wedget anteriorly here. If you're tight, you don't want to buy wedgets, just use rubber bands. Work just the same, cut them up over a lunch hour. I'm also going to do my anchor clamp. So this is my anchor clamp, and I'm now going to ligature my anchor clamp. And this again just increases the seal, improves the seal around this tooth. So I've got my anchorage ligature here, coming out there. Snip it off or keep it long if you prefer. If you do keep it long, make sure it don't get aspirated by your now incredibly high volume aspiration. Your wedgets, keep those tight. You don't want them getting in your way as well. Keep them small, saves money. And that provides anterior stability. Your clamp provides posterior stability, and your frame provides the tension. So you've gone through your contacts. Next step is inverting the dam. And this is what we're talking about here. So this has got to be inverted. Doesn't take long to do. We can use the 3-in-1 air. It's not going to do an awful lot. We could use the floss pull through and putting it over into the cross shape. We can use a flat plastic. That's going to achieve something. But for perfection, the floss ligatures. And you can ligature as many teeth as you want. You might be just doing 2 or 3, or ligature all of them. Then you'll assess your dam. Are there any leakages? Are there any weak points? At this point, a little bit of an area of weakness here. So let's get in and augment that with PTFE tape. Buccal, lingual. And finally, if we really want to improve everything, go with blockout gel. Very cheap, very thin layer. Make sure it's dry before, and then just light cure it. There have been instances where people have been sued for, in endodontics that have gone wrong with hypochlorite failure, for example, when blockout wasn't used. So for example, if you're doing endodontics, one tooth, using a lot of hypochlorite, mention that you've used blockout gel around you, in addition to your clamp and your ligatures. Really important. Keeps dental law dickheads off your back. Another useful technique is the split dam. If you're not deciding not to use the Brinker clamps or the 212 to retract the tissue, and when placing veneers, you can use on the left-hand screen here, 3 larger holes, 1, 2, and 3, in like an isosceles triangle. Then large holes using your clamp, your punch, your Ainsworth punch, and then just cut a nice little elliptical shape. Some people do a triangle. I like to do a little bit of a mild arch, and that shows you then relief that over. This technique, we're going to put the clamps on first. So it's danger time. What happens if I turn around, I go back, and then the patient has moved and I look back and the clamp's not there? If I'm lucky, it's on the floor. If I'm unlucky, it's down the throat. So here I've just put simple loop, both sides, two floss on both, one on each side, one on each side. Place those. Important. You might say it'll never happen to me. Never happens to me. It can happen to you. So I've got my clamps in place. I've got my safety ligatures in, 4-point contact. Then I've got my split dam. Chop a bit off there. bit of silicone to seal the dam. And if you look from the anterior, if we wanted to improve this even more, we could then use some cyanoacrylate glue, some tissue glue, and glue that down. And that will give us a really good split dam for access for your restorative procedure, say upper 3-3 veneer cementation. This was one from today, actually. So sometimes the questions, this is an endodontics, upper left 7. Really, really deep mesial box here. So I'm doing the endodontics. It's going swimmingly. Couldn't find the MB2, which means there isn't one. And I thought, shit, I'm going to have to restore this in 20-30 minutes. So I'm going to do this. So I used a ProMatrix band. It's really, really deep. It's about 2 millimeters subgingival. So isolation is key. I wasn't confident with a sectional band, so I used a circumferential. What I did was I just released the clamp slightly here, released it with one hand, then quickly jammed the matrix in and put the clamp back on. So it was a bit of a juggling act, but with rubber dam, you've always got to be learning. You've always got to be thinking laterally to get you out of scrapes, get you out of holes, create solutions. Now, maybe this is if you don't like the frames, one of the Tipton trainers, Ash Rayrell, pots of money, doesn't like the frames, so he buys these. These are made by Ivoclar, but for me, they're too expensive, so I won't use them, and I don't need them, but nice. It's got a little rubber frame. Tells you where to put your holes in, but in my opinion, expensive, unnecessary. Optrogate, pretty useful. Again, instead of a split dam, this will give you, won't be as good as a split dam, but it gets the tissues out the way. Quite a useful thing to have in the storeroom, get it out and use that. So isolation is crucial. How you achieve it is up to you. And just because you've got rubber dam on doesn't mean that's the panacea for success, because rubber dam can leak. I was doing some diastema closures, lower 2 to 2. I made the holes too big this week. And no matter what I did, I was packing with PTFE. And after 30 minutes, I just sacked it off, took it off, redid it with smaller holes. Then I could get good tissue retraction without the leakage. So you've got to be prepared to adapt. So rubber dam, just because you've used it, you could get all sorts of leakage, but it can improve your restorative dentistry. But you've got to adapt to achieve your aim. You've got to be versatile. Once you've achieved it, you've got your isolation glued to your heart's content. With CQC, we had our CQC inspection in December. I must say it went very well. Great guy, the dentist who is part of the team, a guy called John Lewis from Cumbria, Penrith, got fantastic practice there. Proper dentist. Yeah, he asked me some questions, but one important thing about your CQC inspection is you should have a rubber dam policy. So it states that I use non-latex dam for all endodontic procedures, as we should do, all medical legally, and it just tells in my policy, it says how I place the clamp and the tooth first and the dam at the same time, blah, blah, blah. If you want that, I can email it to you. This is a great paper by Stefan Brouat and his colleague David Godole. Do a search on Google PDF, and again, it gives you some really, really useful techniques. So I hope you've enjoyed this afternoon. We're just about 50 minutes. So if there are any questions, got a couple of questions. Okay, so question number 1. What is the name of the expert in rubber dam that you mentioned at the beginning? Stefan Brouat, Brouwet. It's from Belgium. Really, really useful. Question from Catherine. When placing rubber dam, do you tend to put the clamp on first and then stretch the dam over it to place both together? The answer to that is I place it 99% of the time both together. Where do I get the rubber dam from? Dental Directory is cheap, cheerful, nice light blue color good for contrast photography, etc. So Dental Directory is a secondary. I would use the Roeco dam, but it's the purple. It's very, very good for getting it over large numbers of teeth, but I don't like the color as much for photographs. Really broken down teeth, good question. You've got to be aggressive. You've got to give local anesthetic. The cavity may be 2 millimeters subgingival. I may use some electrosurgery to cauterize to get access. But where there's a will, there's a way. But if you haven't got local anesthetic, you won't be able to do it. So that 212 clamp, very, very good, very aggressive. It pushes the tissue out the way. Can we see the last article? Yes, you can. So I'll come to that in a minute. Can you have a link to the video? Yep, I'll sort that out with Lou, and she can arrange that, or Kath in the office. Okay, I'm just going to come out of Q&A. So this was the article by the Harry Potter of rubber dam, Stéphane Brouet. He does a lot of microscope dentistry, high precision, superb clinician. And the article is Precision and Security in Restorative Dentistry, the synergy of isolation and magnification. So what he achieves absolutely outstanding results from rubber dam. He does a lot of YouTube videos as well. That's where I first saw him about 6 years ago when I was starting to try and improve my rubber dam isolation. Once again, what I like about rubber dam is it stops patients talking to me. And after 32 years in dentistry, and particularly after COVID-19, I'm back working with, we're doing aerosol generated procedures. I'm coming home every day. I'm washing gowns, and I could do without patients talking to me all day. So let's just check I've got all the questions. So really broken down tooth. Yep. Okay. So matrix band and spaces. Okay. What is the purpose of using specifically wax floss rather than unwaxed? I just prefer waxed floss. It slides through contacts better. I use a Teflon coated floss or waxed floss. So it's just better in my hands. It doesn't shred as much. Is the frame best placed over or under? That's a little bit like toilet roll. Should the toilet roll go over? The answer is definitely yes. Should it go under? No, because it's not ergonomic to go. The toilet roll always over. Personally, I put the rubber dam over the frame, but a lot of colleagues put it under. So whatever you prefer. Shaysta from Dubai. Hi, Shaysta. Are all your patients cooperative with having the rubber dam in place? And do you include the price in the procedure? No, they're not all cooperative. Some of them don't like it, and we show them the door. If they're not going to cope with the rubber dam, certainly for endodontics, I won't do it. Restorative, sometimes I'll wing it without it, but most of the time I'll just try and persuade them. Very occasionally you get somebody who's a bit claustrophobic, but they're going to be claustrophobic with anything I do, so I try and get rid of them. Do I include it in the price of the procedure? Yes, I do. I don't think it's an essential part of the procedure, but it's costed within the procedure. Matrix banded spaces. I'm not sure, Beverly, what the question is there? Let me try and second guess you. So placing matrices, sometimes the wing might get in the way and you might have to cut off one of the wings. But generally that's thing. Do I have a system for choosing the hole punch, the holes? I'll try and go as small as I can for the holes. I prefer the hole too small than too large. Try and avoid very, very large holes in the dam because it'll get leaks. But it's trial and error. If you've got big gaps, go for a smaller hole. So where do I put the clamp on when they're doing a class 2 filling on a second molar if it's the last tooth in the arch? This is a good question, Patricia. So if it's an MO, it's not a problem because I'll use a slightly smaller clamp. I might use a 2A premolar clamp, which will give me space. If it's a DO, that is a problem. And sometimes what I will do is I will try and hold, I'll get the dam on first with clamps, and I'll try and at the same time put a matrix band around the tooth, like I showed you near the end, like the case I did this afternoon, where I'll open the clamp a little bit and quickly just go in and get the matrix on. And sometimes I'll do it without rubber dam. I'll just build up that distal wall. If it's not subgingival, I'll convert the tooth from a DO, a lower left 7 DO into a lower left 7 occlusal. Then I'll put the rubber dam on. So I'll accept a bit of a compromise. I'll be working with cotton wool rolls. I'll be working quickly. I'll get that distal wall built up. Then I'll take it. Then I'll get rid of my fingers, cotton wool rolls. Then I'll put the rubber dam on. How to use the Paladent kit and bands. The Paladent is very similar to the Garrison and the V3. Always try and clamp the tooth behind where you're working. And you shouldn't have any problems. Certainly, I love using sectional bands. They're my treatment of sort of class 2 solution, matrix solution of choice. I like using, Alistair's asked about what system do I use? Well, I'll use loads of different systems. So if I'm using sectional, I will use largely the Garrison system with a 3D XR ring and slick bands, and then some fusion wedges, which really, really neat. They've got little legs on which help stop them slip, or I'll use wedge ones. I'll use circumferential on occasions, where I'll use Pro Matrix Curve. They're made by Aztec Solutions. So, question from Dr. Isra. Largely, do control the bleeding once the dam is in place? Yeah, largely because I won't have done any restorative dentistry until the dam is in place. But I will. If you do get some bleeding from, say, a mesial box, for example, you do need to stabilize that bleeding. So I'll do that with either electrosurgery, PTFE, a viscostat, or a cord, a retraction cord. How good are mini dams from DMG? I've seen them. They look really fiddly to me. And the patient might be able to talk. So they're not for me, but I'm an old dog who doesn't like new tricks. How much does this reduce your fallow time? This would depend on, for those that are listening in Dubai, you might not have fallow times, but in the UK, we have a fallow period now, or as the academics call it, a surgery latency period. God's sake, man. So this is a time spent where you shouldn't be using the surgery, where aerosols settle and then you go back in and clean it. You have to risk assess the procedure. If you're using high volume aspiration, using rubber dam. So in endodontics, I may only be doing an aerosol generator procedure for 2 to 3 minutes. Quickly gain access. The rest of the time there's no aerosol. So it's a risk assessed approach. Bear in mind air circulation per hour, bearing in mind high volume aspiration, how many liters per hour. The rubber dam, so I have risk assessed my procedures and I can reduce my fallow period with all the measures in place down to 20 minutes. That is my opinion. Whether it's right or wrong, I don't know. There's no evidence. Salah, I have shown you the article. So, okay. So the last question, do you have any tips on how to isolate mesially drifted teeth or malpositioned teeth? My answer to that would be just really just got to try it, see, create the solution, put the holes in the places you think, or if it's mesially drifted, you may have to guess at the hole position. And it may be that it will stretch the dam a little bit too much and you'll have a potential gap. That's where your block out comes in really, really well. So I think that answers now all of the questions. I hope you've enjoyed the webinar this afternoon. I would like to thank Professor Tipton for putting on an amazing array of webinars over the COVID-19 crisis. And also say thank you to all my colleagues who've taken part in these webinars, and I know there's more to come. I thank Lou and Adil in the back office for doing all the logistics. And a big thank you to my pal Ian Mills, who's Dean of the FGDP. He doesn't get celebrated on social media, but he's put in a hell of a lot of work, him and his team. And I'd like to say thank you to him. He's a great guy, qualified year above me, and amazing guy, amazing clinician, and does an amazing job for British dentistry. And I'm sure it's a guide for all dentistry. So thank you very much for your time this afternoon. Stay safe. I hope you'll get back to work very, very quickly, doing a normal dentistry, enjoying your dentistry. Get to grips with rubber dam because it makes dentistry far more enjoyable, far more successful. Good luck to everyone. Take care now. Bye-bye.